Mumbai, and this evening's lecture I'll be talking on surgery of atrioventricular septal defects. And we all know that atrioventricular septal defects is not a very uncommon condition, but forms about 3% of all major congenital heart defects. And nearly 50% of these have got Down syndrome. And amongst those Down children, AVSD constitutes about a quarter of the cardiac defects seen in them. But if you take general population, it's a 1,000-fold increase in the risk compared to the usual population. Coming to pathology and embryology, it's a wide spectrum of lesions, the etiology being abnormal development of the endocardial cushions, and the defect is in the atrioventricular septum and consequently in the atrioventricular valves. And usually they are also associated with some associated lesions, either it could be major or minor. Now coming to for those of you who are not very familiar with the actual anatomy, what you see on your left side is the normal heart, that's the tricuspid valve, that's the mitral valve. And you find here the tricuspid valve, the mitral valve is a little higher than the tricuspid valve, that's what it should be. But if you come see on the right side, this is the area which is the problem area in atrioventricular septal defects. That's the tricuspid, the mitral, the primum, the low part of the atrial septum, and also the upper part of the interventricular septum. So that's what I call the business area of the lesion. Now, since this is a surgical lecture, you can't run away from understanding the anatomy of it because that's what we'll be fixing. And the first thing to understand is the atrioventricular septum is deficient. So both the mitral valve and the tricuspid valve at the same level. As I told you earlier, the mitral is usually higher than the tricuspid valve by a few millimeters. Ventricular inflow is shorter. It's more so in complete AV canals than partial AV canals. And the LV outflow is longer, giving rise to what's commonly called as a gooseneck deformity. And in the normal heart, the inlet and outlet lengths of the left ventricle are equal. And therefore, this predisposes to the left ventricular outflow tract obstruction. And aorta is more anterior and unwedged. I'll be showing to you these in a more diagrammatic form. And this is what it is. Here, the atrioventricular septal, the valves are more deviated towards the apex, and you find the inflow is much shorter than the outflow, and you can see the crowding of the outflow here. And this whole thing is called the gooseneck deformity. And here, that's what it sees, and I've drawn some arrows for you to understand. And this is not usually seen nowadays because we don't study these kids. Mostly we diagnose it by echo, but this is important to understand that the inflow and the outflow are not normal. So therefore, left ventricular outflow tract obstruction is more common and more so in partial AV canals because all the subvalvular chordae are attached in the LV outflow. So therefore, in a complete AV canal, you can get a free-floating leaflet where there is not much of subvalvular anomalous adhesions and also where they arise. But in the partial AV canal, you find all abnormal chordae and all this arising, and you can get LVOTO. This is one of within the transverse section of the heart. For those of you who are adept at echoes, you may be able to immediately spot this. This is a normal heart, that's a mitral valve, that's a tricuspid valve, and here you find the aorta is nicely wedged between the two valves. But in the AV canal, you find that the aorta is not very much wedged. So therefore, the aorta is more anterior, and this also contributes to the left ventricular outflow tract obstruction. There is also an inferior displacement of the AD node in the coronary sinus, and the bundle of hairs is also displaced inferiorly, coursing along the inferior rim of scooped out or the basal part of the IVS. This is extremely important to the surgeon to know that because as you can see here, this is the normal heart, this is where the node and the bundle is, and this is where in the AV canal you find it is displaced more posteriorly, and you find this is on the posterior inferior part of the scooped out atrioventricular septum. And once we go or once we open, this is what the surgeon sees. And this is the right atrium which has been opened. This is the coronary sinus. This is the margin of the ostium primum ASD, and this is the atrioventricular, the common atrioventricular wall. And as you see inside, this is what you can see into the ventricle. I'll be speaking to you more on this, but just keep in mind, this is the view you will always have to know to understand AV canals. Now, basically, coming to the types of AV canal, the types of AV canal is based on the type of interventricular communication and also separation into two distinct AV valves. So therefore, you have got partial types of AVSDs, intermediate or transitional types of AVSDs, and complete types of AVSDs. Let's see what these three types are. The first one in a partial AV canal, as you can see here, there's a large primum ASD, which is not illustrated in this diagram. The cleft between the left superior and the left inferior leaflet, that is the cleft which you are seeing. There is no VSD in a partial AV canal, but there are two distinct atrioventricular orifices, and it forms about 5 to 10% of all AVSDs which we see. So that's the coronary sinus, that's the AV node, that's the right AV valve, and that's the left AV valve, and that's the cleft you find between the left superior and inferior leaflet. Then we have the transitional intermediate AV canal. It's very similar to the partial AV canal, excepting for the fact that there's a small to tiny, but it's a restrictive VSD. That's the most important thing to understand. The VSD could be between the chordae and the attachments of the chordae, but certainly it is a restrictive VSD, and these children will not go into developing pulmonary vascular disease, and they very much behave like a partial AV canal. Now, coming to complete AV canal, it is called an ostium primum ASD. There's a large unrestricted VSD, and there is one common orifice. Unlike the other two which have two orifices, here there is a one common orifice with left and right components, and you find the superior and the inferior bridging leaflets. So this is the complete form of the AV canal. The other features of anatomy of significance to a surgeon, particularly, and I think those of you who are cardiologists should see to it that you give this information in your echocardiography or whatever it is to your surgeon, is the fact that the size and extent of interventricular and interatrial communications, valve leaflet morphology, papillary muscle anatomy, valvular regurgitation, and attachments of the chordae to the interventricular septum, relative balance of the common AV valve orifice over the ventricles, and other major associated cardiac and non-cardiac defects. So in addition to the anatomy, I think these are all important for the surgeon to know before he goes in to repair the AVSDs. One of the most important things in surgery of AVSD is the left-sided AV valve. Now, at the bottom of your screen, you will find what is a normal mitral valve. It is called the happy mitral valve. And what is the left AV valve in common AV canal? It is called a sad left AV valve. And you can see the difference here. Normal, where you find the AML forms about a third of the circumference, and 2/3 is formed by the posterior mitral leaflet. Whereas in AV canal is exactly the opposite. This is what you find when we repair and close this cleft. That forms what seems like an AML, and the posterior mitral leaflet is just about a third of the circumference. So therefore, a left AV valve after repair in complete AV canal or AVSD is inherently stenotic. Anterior mitral leaflet occupies more circumference of annulus than the normal mitral valve. Cleft is not a commissure. This cleft is truly not a commissure. As you saw earlier, it is a space between the two bridging leaflets. It lacks support, and it is a space between the two bridging leaflets. So therefore, it's not a commissure. That's important to understand. And annular dilatation predisposes to commissural regurgitation. Because it's a left ventricular volume overload condition, the left ventricle dilates and you start getting leak in the cleft. Now, all of us know that AV canal has been classified according to Rastelli classification, which was done by Rastelli in 1966 from the Mayo Clinic. It's based on the extent of left superior leaflet bridging over the interventricular septum, and it's subvalvular and caudal attachments taken together. But it does not take into account the left inferior leaflet, and that displays greater anatomic variation. So therefore, this classification has got an inherent problem because it takes only the superior bridging leaflet and not the inferior bridging leaflet. So as you can see here, this is the appearance of the complete AV canal, the Rastelli type A, B, and C. And please concentrate only on the superior bridging leaflet. Here you have the right part, the left part, which is divided, and there's a lot of chordae attaching to the crest of the interventricular septum. Then you have type B, where you find there's a larger left side, or it could be a larger right side, but there's an anomalous papillary muscle on the right side of the ventricle. And in type C, there is not much of attachment. It is a free-floating leaflet. Mind you, in Rastelli classification, there is no description of the inferior leaflets in any of the A, B, or C. No description of the lateral leaflet, and though these form parts of the AV canal when you repair them, especially the clefts when you close them, so that is the drawback of this classification. So how useful is the Rastelli classification? Not very useful, but it was useful when we used to when you repair with a classical single patch technique, which is more or less been given up to a modified and a double patch technique. The recognition of the extent of the undivided portion of the superior leaflet over the interventricular septum was important in those days in this type of technique. But in the current techniques, the Rastelli classification is far less important. Now let us see what's the pathophysiology of this, because that's important. There's a large left to right shunt at atrial and ventricular level, coupled with mitral regurgitation. And if the MR is more, this augments the atrial left to right shunt fraction, leading to early onset of PH and also much earlier in cases of Down children. The reasons I'll be telling you a little later. Now coming to the management of AVSDs, how do we manage this? This is a lesion which surgery is the only management across the ages. But there is a place for medical management, particularly at the extremes of life in neonates, early infant age groups, when there is when there is a contraindication for surgery. So, what are the medical managements available? Well, it is something to tide over the child till it comes up for surgery in the form of diuretics, ACE inhibitors, or digoxin. Well, this is controversial. Some people don't believe in digoxin, but however, these are the usual drugs given till the child comes up for surgery. Coming to the diagnosis, I think ECG gives you a hint, and we all know it's a left axis deviation. In one of the rare causes of left axis deviation in the child, you have to suspect ASD, particularly AVSD, particularly when you see an ASD. 2D echocardiography, which is more or less most important diagnosis modality at the moment. 3D is threatening to give us much more information now, and post-operatively, I think epicardial echocardiography and transesophageal echocardiography, 2D or 3D, is extremely important to assess the repair and also residual lesions and the mitral regurgitation. Now, what about catheterization? I think it's not really the first line of investigation currently. Older AVSD patients more than 1 year to assess the pulmonary arterial pressures, PVR, and also to measure the QPQS. I think there's a place for that. And post-operatively to quantify residual lesions like VSD, LVOTO to decide on when to reoperate. I think currently these are the only two indications for doing catheterization for this lesion. What are the indications for surgery? Diagnosis of AVSD is an indication for surgery. The timing of surgery could vary depending on whether it is partial AV canal or transitional AVSD around 1 to 2 years of age, because this is one with a restrictive VSD or no VSD, so their chances of developing pulmonary vascular disease and pulmonary hypertension is pretty remote. If it is a complete AV canal with unrestricted VSD, ideally we need to operate around 2 to 4 months of age, but certainly earlier than 6 months of age, or even earlier if the child is symptomatic, not responding to medical treatment, or goes into congestive failure. But those AVSDs where they have a reduced coronary blood flow, like tetralogy with AVSDs, maybe I think one around a year of age, and if some of them, if they're very cyanotic, may require to be shunted when they are young and then brought up for surgery at a little later date. What is the place of palliation in the form of banding in complete AVSD? It's very rare in current practice because we are repairing these children much earlier or early infancy. But however, in those AVSDs as an unbalanced AV canal, associated lesions going into the univentricular pathway very early in infancy when you're not ready for a Glenn, I think that's one of the indications currently for temporizing with a pulmonary artery band. Or there is some medical contraindication to surgery in the form of major other system anomalies, or the child is stuck on the ventilator for some lung issues, or other comorbid conditions when they are still unfit for complete repair. This could form another indication for palliation. Certainly, contraindications for surgery are present. Resting saturations in a child below 85% on room air unresponsive to oxygen inhalation when the saturation goes up. Or if a child is a little older, exercise desaturation certainly form one of the things we need to look out for whether surgery is going to help this child or not. A small heart on the X-ray with no pulmonary plethora, predominantly right to left shunt with no reversal with oxygen or pulmonary vasodilators. I think all taken together forms contraindication for surgery. Now coming to the surgical aspect of it, what are the aims of repair? I think the aims of repair is one, to close the shunt, that is in the atrial level, in the ventricular level, and also in between the valvular level. And other thing is to rebuild the mitral and the tricuspid valves to make them competent and functional. Now, what are the modes of repair for AVSDs? There are actually three modes. One is the single patch, as you can see here. This is one patch, and we used to divide these leaflets to accommodate this patch, the atrial side of the patch, the ventricular side of the patch, and close the cleft in the mitral and tricuspid valves. Now, this was very popular in the early to 70s to mid 80s, but then the incidence of neck AV valve regurgitation was extremely high here, and this technique is more or less been given up and is given way to the two-patch technique, where we close the BSD with a synthetic patch, we close the ASD with pericardium, and then we make these into two valves, the mitral and the tricuspid. In the early 90s, the Australian group have started this technique that's called the modified single patch, where the BSD is closed directly without a patch, and the ASD part has been closed with pericardium. So, though the original authors applied this to all the techniques, but I think now it is sort of popular in the transitional and also in a sort of a smallish BSD patients. But generally, as always, most of the complete AV canals are repaired by the two-patch technique. What are the steps of repair? We close the inlet VSD, we close the primum ASD with pericardium. We don't close it with synthetic materials because sometimes the mitral jet hits that and you can get hemolysis from that. So always the primum ASD is closed with pericardium. We create two competent non-stenotic AV valves, at least we aim to do this. Close the anterior mitral leaflet cleft, repair the tricuspid valve. This is one thing that is not paid attention to, but it's also extremely important in the long term. We should also try to make the tricuspid valve as competent as possible. Avoid damage to the AV node and bundle of his by carefully placing the sutures in this area, and of course repair associated lesions, like if LSCC is draining into the left atrium. Because LSCC is a pretty common issue with this. Sometimes ungrouped coronary sinus, PDA, they all have to be fixed in the repair. So just to, once again, this is what a surgeon sees, and this is how the repair is done, where we close that. This is you're seeing through the valve, and you find that is the crest of the VSD. This is the left side, that is the right side, and you find once the VSD is closed, we use a pericardium to close and separate the mitral from the tricuspid valves. And for the surgeons, I think this is important because this is not a correct way to do. We need to take the opposing areas together because if you take like this, there will be too much of wall tissue and it may start to give a cut through or it may start to leak again. If it is a transitional AVSD, as I told you earlier, with restrictive VSD, this part of it is closed directly and the mitral cleft is repaired, and then across this, the pericardial patch is put and the ASD, osteoprimum ASD, is closed. So the VSD or the interventricular communication is closed in a direct fashion. A few words of repair of the left AV valve, as you can see here. As the surgeon sees, this is what the left AV valve looks like. That is the inferior bridging leaflet, that's the superior bridging leaflet, that's the commissure in between, and we're trying to close that. That's a cleft, is what we all call these. And then you have a sort of a commissure between the bridging leaflets and the lateral leaflet. And very frequently, what you find after we have done this repair, there is usually a central leak. This is how a valve is tested. We inject into the ventricle, and once the leaflet balloons, we see the area of leak. And if you find that there's an area of leak in any of these two commissures, we sort of use this small annuloplasty or plication sutures to reduce the size of the annulus and control this leak. But if it has to be judiciously done, because if you don't take care, the valve can become stenotic. Now, of late, we do get annuloplasty rings, especially absorbable annuloplasty rings. Well, whether they're superior to this or otherwise, it remains to be seen. But you either take annuloplasty or plication sutures or put in a ring to control the central leak. Now, there's another technique to avoid heart block, and that is when not only when we close the VSD, but also when we close the ASD. So what we do is sometimes we go around the coronary sinus in the suture and direct the coronary sinus into the left side. So we might get a little desaturation, about 2 to 4% desaturation, but then it avoids heart block. But in those cases where the left superior vena cava empties into the left atrium or into the coronary sinus, you can't direct the coronary sinus into the left side, and you try to go follow the annulus of the left AV valve around the AV node and close the primum ASD. So if the coronary sinus doesn't receive the LSVC, we can direct it into the left side. But if you find that the LSVC drains into the coronary sinus, we need to keep it draining on the right side and then go around the AV node. One of the technical aspects, especially for the surgical audience, is how do you size the VSD patch in AVSD? I think it's extremely important because the left AV valve regurgitation depends on this. So normally you have two dimensions here, that's the width and that's the height. If you make the patch too wide, there will be distraction of these commissures and you will have AV valve regurgitation. If you make it too long, you will have disorientation of the two valves and you can have left AV valve and the right AV valve regurgitation. So therefore, it has to be appropriate, and we need to see that the patch is a little undersized than being oversized, so that the two leaflets come together and you can have a reasonably competent left AV valve. This is just to show you the surgical thing. This is what the surgeon sees. This is the right atrium which has been opened, and that is the right AV valve. This is the left AV valve. We are seeing through the primum ASD, and the left ventricle has been filled up. This is a partial kind of AV canal, so you see the leaflets which are floating up, and this is the inferior bridging leaflet. This is the superior bridging leaflet, and that's a cleft in between the leaflets. And this is another transition type of AV canal where we have taken the small VSD sutures, come out on the annulus of these two valves, and this is the left inferior bridging leaflet, that is the cleft, and this is the primum ASD, which we'll be closing later on. And that is the left AV valve where it has been closed, and that's a pericardium which we are using to close the. So that's the coronary sinus, and I told you, if we find that this coronary sinus doesn't receive the LSVC, we go to close like that to avoid the bundle, or we just follow the annulus of this and close the time of ASD. This is a picture of one of the rarer problems of complete AV canal. It's a double orifice mitral valve. There are two orifices, you can see, and this is difficult to repair, and especially if it's a partial type of AV canal, it is best left if it is not stenotic. As anything you try to do, we might make the valve incompetent, and it's very difficult to repair this. But certainly, in the long term, they do give rise to trouble. Associated anomalies seen with AVSDs are LSBC, unroot coronary sinus syndrome, PDAs, coarctation. The second MAS is muscular VSDs, tetralogy, DORV, TGA, etc. A few words on Down syndromes. 20 to 25% of the Downs have AVSDs. They've got hypotonia, CO2 retention, leading to high pulmonary pressures, early PVR, smaller airways, reduced number of pulmonary arterioles in the vasculature. Their ICU stay is longer. PA crisis is more in the older patients, and the Rastelli type C are commoner. But surprisingly, surgical outcomes are far better in the Downs because of the free-floating leaflet and less incidence of LVOTO long term. There is another group called unbalanced AVSD seen in about 5 to 7% of patients. The RV dominant form is more common. The left-hand hypoplasia is seen in these kind of patients. There is always a decision to be made between biventricular or univentricular repair, and there are a lot of these criteria which are set, which permits biventricular repair in cases of unbalanced AV canal. But what they all forget to see is the growth potential of the left ventricle. So if they satisfy most of these criteria, we do a biventricular repair, or you take them along the univentricular pathway. Whenever we do the AV canal repair, there are certain residual lesions which are present. One is mitral regurgitation, tricuspid regurgitation, very rarely residual VSD, and of course LVOTO. Either it is seen or they develop as the child grows. Post-op issues of complete AV canal repair, the usual monitoring lines that we put are arterial PVP lines, and at least I put in LA and the pulmonary arterial lines. Then we always measure the RA and PA saturations to know if there is any residual left to right shunt. If it is more than 10% or an absolute PA stat less greater than 80% with an FRT of 0.5, it certainly indicates a left to right shunt, possibly a QPQOs of greater than 1.5, and that needs attention. Some of them, they do go into low cardiac output state for some period post-operatively, and we need to judiciously use inotropes more than volume, because particularly milrinone and vasodilators reduce the LV volume by reducing the HVR, and we should not give too much volume because the LV dilates and the regurgitation increases. pH is seen post-operatively, and if it is seen, I think we, in addition to the crisis and the reactivity of the pulmonary vascular bed, we have to see for severe mitral regurgitation or stenosis when it's overcorrected, residual VSD or LV dysfunction from any cause, and that has to be ruled out before we could label it as a pulmonary arterial hypertensive crisis. Outcomes of closure, the current accepted mortality for AV canal defect is particularly common AV canal is about 1.5%. Trivial to mild MR is seen in about 2/3 of cases post-operatively, moderate in about 10% of these cases. But the surprising thing is there's no correlation between the presence of MR preoperatively and its present post-operatively. So because of the morphology and also the type of repair. This is just to show you that over the period, the mortality has reduced, and this is taken from an old publication by John Kirkland, and you find even currently it's in the region of about 1 to 3%. And if you see this, the survival certainly it's not a straight line, so there is some attrition as the follow-up duration increases, and attributable mostly to the function of the left AV valve and to the left ventricular outflow tract obstruction, if at all it develops. And if you see here, partial AV canal obviously has got a better survival than a complete AV canal over a long period of time, and nearly about 90% survival over 20 years, and little less in the complete AV canal. This is old data, but currently it is far better than this. Long-term issues to be seen are left AV valve regurgitation, right AV valve regurgitation, residual shunts, left ventricular outflow tract obstructions, residual pH if the AV canal is corrected at a much later age, and of course issues of permanent pacemaker changes if the child itself a complete heart block and needs PPI changes. Coming to the risk factors, early era of surgery was a risk factor. Older age of surgery because the residual lesions are more, residual pH is more. Post-operative left AV valve regurgitation, pre-operative left AV valve regurgitation predisposes to some extent the post-operative left AV valve regurgitation because of the morphology. And of course, if it is a double orifice mitral valve, it is certainly a risk factor for late development of regurgitation as the follow-up increases. And this is just to show you that it's a hazard function curve of AV valve failure, and if there is no AV valve failure, virtually it's more or less like a normal curve. But if the AV valve failure is there, as the follow-up increases, the hazard function increases. So what are the issues in surgical correction? I think I've answered you when to correct. Describe to you the technique of correction. Cleft to be repaired, yes and no, but certainly it is always a yes currently, because we know if we don't close the cleft, the incidence of left AV valve regurgitation in the future is very high. How do we close the cleft? Well, it is usually by direct sutures and seeing to it that we don't take too much of tissue when we are closing the cleft. How much MR to accept, and whether to overcorrect leading to stenosis? No, I don't think we should just accept a trivial to mild MR at most, but certainly not mild. Anything more than moderate is unacceptable, and we should not overcorrect and cause stenosis. Coronary sinus could be left into the left atrium to safeguard the AV nodal and conduction tissues if the left SVC is not draining into the coronary sinus. Otherwise, we'll have to take superficial bites and see that the coronary sinus is in the right atrium. And monitoring lines, it's always judicious to put in LA and PA lines in addition to arterial and PVP lines. So in conclusion, AVSD has varying degrees of atrioventricular valve abnormalities, interatrial interventricular communications. Complete AV canal is best operated and dealt with in between 2 to 4 months of age. Repaired earlier if there is congestive heart failure or if the AV valve or left AV valve regurgitation is moderate to severe. Unbalanced AV canal presents a management dilemma between biventricular repair and univentricular repair. We don't have hard criteria to choose either pathway, but of course, if we can do, we prefer to a biventricular repair. Currently, AVSD can be repaired with very low mortality and morbidity. Left AV valve regurgitation and left ventricular outflow tract obstruction determine long-term outcomes. Thank you very much, and from Kokilaben Hospital. So, complete heart block is in the region of about 1 to 2%, 1% I would say. It's not very much if you take proper care and you know the anatomy. Tetralogy of fellow with complete AV canal. I think the most important thing is to size the patch properly, because especially when there is a deficient in the coronal septal area, the patch has to be sized absolutely appropriately. Otherwise, you can develop left ventricular outflow tract obstruction if it is made to be very narrow, or the patch could rip away, and you can have a what do you call residual VSD. In addition to that, the left AV valve has to be repaired properly, because especially if you are putting a transannular patch, you find that if you have a TR and an MR, the volume load will be too much for the heart to handle. So the important thing in tetralogy with AV canal is to size the patch properly and to do the best you can to ensure it's a competent AV valve.